I'm just going to get the presentation going. Sorry, folks, just taking a minute to get all the technology aligned here. It says, I'm getting I'm getting the feedback. It says you cannot start screen sharing while the other participant is sharing.
I think you should be able to share now.
Okay, thank you. Sure, okay. All right, so this presentation. Okay. So as Audrey mentioned, this is a presentation on learning to sleep better, and it's really founded on a lot of the principles we use when we're treating someone with insomnia. So this is a screen I like to show off. This is actually my 3-year-old, actually just turned 3-year-old on Thursday here, where she's mimicking her mother, who is often on her phone and on her computer, and even at times in bed, which is a whole other conversation here. But anyway, so that's my daughter Tal. So the presentation is going to cover 3 general categories. We're going to talk about normal sleep, because it's helpful a lot of times to understand how to get sleep better under control or manage if we understand the foundations of how sleep works. We're going to talk about insomnia and really what causes it, as well as steps to improve one's sleep. So oftentimes people are under this misconception that when we're sleeping, sleep is a passive state. And the reason being is when we see someone sleep from the outside, they oftentimes are either quiet, or unless they're snoring, there's very little movement. And from an outsider's perspective, it looks like there's not a whole lot going on. But in reality, there's a lot that changes when you go from being awake to being asleep. First of all, there's an alteration in our consciousness. We go from being alert and aware of our environment to losing that alertness or awareness. Our muscles go from being tense or contracting and expanding to becoming flaccid. And that's one of the reasons why, unless you have some sleep issues, you don't move while you're sleeping. Our breathing slows down, our heart rate changes, and even our body temperature changes. And even while we sleep, that is not constant, because as we circulate between different stages of sleep, our body temperature, breathing, heart rate can go up and down. Now, there are 2 main categories of sleep stages. One's called non-REM sleep and REM sleep. REM sleep is when we do most of our dreaming, and it's towards the tail end of a sleep cycle. Non-REM sleep, which we have 4 stages, is really where we have both light stages of sleep and our deep restorative sleep. So the way a sleep cycle works is we enter sleep through non-REM 1, we move on to non-REM 2, and then we get into non-REM 3 and 4, which is our deep sleep, and then REM sleep, and then we start all over again. And we do that typically 3 to 4 times a night with healthy sleep. Now, what I also find is helpful to understand why we even struggle with sleeping as adults is this general concept to be aware of that we're not born good sleepers. Anybody who has had children or babies will tell you that it's actually a pretty trying time until the infant or baby is sleeping through the night. Prior to that, the sleep, while it is quite a lot in volume, it's fragmented and very irregular. So eventually when someone becomes infants, we start talking about this idea of either learning to sleep or being trained to sleep. And this concept actually helps us understand insomnia as an adult. Now, sleep training, or what we do for infants, or learning to sleep, is largely based on a learning theory called classical conditioning. Probably the person that's most linked to it is a guy named Pavlov. And Pavlov developed some notoriety for one of his experiments. He was able to train a dog to drool to the sound of a bell. And the way he accomplished that is he would repeatedly pair exposing a dog to a substance that on its own caused drooling, and would pair that with this neutral bell. And by pairing these things together over and over and over again, eventually he could just ring the bell and the dog would drool even without the substance. Well, it's the same concept that underlies sleep training infants. These days, if someone were to ask for some advice from our sleep specialist, we'll typically advise them, if you want to sleep train your infant, you don't put them down after they've fallen asleep. Instead, you put them down while they're still awake, go drowsy. And the reason being is drowsiness leads to sleep on its own. And by being awake, even an infant, there is some awareness that there's some movement going on. And what we're essentially doing here is we are pairing the action of going down with a sensation of drowsiness. And as we pair these things together over and over again, the eventual goal is going down into bed itself or into the crib or bassinet or wherever they may be sleeping becomes a trigger for drowsiness, which leads to sleep. And that is why if anyone's ever been around a successfully sleep-trained infant, it is very easy to get them down. You literally could just take them to their bassinet crib and put them down and walk away. In contrast, when they're not sleep-trained, if anyone has had that, that's also noticeable. You put them down, they often start screaming or crying. So then this concept about sleep training really comes back into play when we talk about insomnia as an adult. So another concept that is helpful to be aware of is our body's need for sleep operates in a very similar manner to our need for food. In fact, we categorize them both as what we call homeostatic drives. So just like, for example, if I were to have a big snack in the afternoon, I may not be as hungry come dinner time. If I have a big nap in the afternoon, I may not be asleep come nighttime. And we find is for a lot of people that have chronic and repetitive sleep problems, it's not uncommon. They do things to help alleviate some of that sense of being tired or sleepy by doing things like taking naps, sleeping late on days when they have the opportunity, or going to bed earlier on other days. But all those things can provide some temporary relief of that discomfort being tired or sleepy. In the long run, they actually feed into the perpetuation of sleep problems because they weaken the body's need for sleep on a subsequent night. Now, the opposite also comes into play. If we want to say, let's say, make ourselves hungrier, well, one of the things we can do is we can delay when we eat. If I normally eat dinner at 5:30 to 6, but I hold up eating until 7 o'clock, I will be noticeably hungrier. Similarly, one of the things we do for sleep, and it's a natural to do this, is we can strategically push our bedtime later and take advantage of the natural properties related to that. The next question is, how does our body know when to be awake or be asleep? Because one of the things we notice is most of us, unless there's something like that we have worked through a shift or some sleep issues, we're basically awake at the same time in a 24-hour cycle and asleep at the same time. And the basis of that is we all have a circadian clock. And what happens is at nighttime and when it's dark out, our brain actually produces a natural version of melatonin. And I suspect many people have heard of melatonin. It's a commonly used over-the-counter sleep aid. And we get drowsier from that. And then we get exposed to sunlight in the morning. That sunlight actually enters through our eyes and leads to the suppression of that melatonin. Now, this is one of the reasons probably many of you have heard is you want to be careful about screen exposure leading up to bedtime because that blue light with energy in it can actually have an impact on our production of natural melatonin. So then what is insomnia? So again, we've talked so far about our buildup of sleep drive. We talked about sleep learning, essentially sleep training, and our circadian clock. Well, if we talk about insomnia in its most basic way, it's either trouble falling asleep, staying asleep, or waking up too early in the morning. However, where it gets a little more complicated is when we get beyond just what we see to what is really underlying it. And one starting point for that is to recognize that insomnia can be a symptom or a condition. Okay, so for example, an insomnia symptom may be something like this. Oh, I have a lot of stress at work. I'm really worried about it, and I'm up at night stressing, so with full stress, so I don't fall asleep. That's an insomnia symptom. That's different than the insomnia condition, which seems to happen over and over again. And the insomnia condition is something that can go on for weeks, months, even years. Now, the insomnia condition usually starts as a symptom. What you find is for most people, there is some understandable disruption of what first set the insomnia up or what started the first 2 nights. But getting back to the whole idea about have rolling or classical conditioning, this is where it becomes a chronic condition. Because a common pattern you'll see unfold for most of my patients with chronic insomnia is they start reacting to the sleep in a way and responding in a way that actually results in the development of the insomnia condition. So you see several common patterns. First of all, you start seeing people spend a lot of time in bed doing things other than sleep. And if we keep in mind how this whole Pavlovian conditioning works, when they do that, they're essentially now pairing being in bed without feeling sleepy. And as they do this over and over again, it diminishes or weakens that trained trigger that we had developed when we were infants. As a result, trying to sleep at night no longer triggers drowsiness. Now, what happens for most of my patients, and just to kind of give you a background, I will sometimes treat patients that have had insomnia for, let's say, a half year. The vast majority of them have had them for decades. Probably the average length is somewhere between 20 to 30 years. And what happens for most people, like anything that is unwanted, undesirable, or even unpleasant that keeps happening over and over again, we're prone to react to it. And this ends up becoming a big feature of what perpetuates insomnia. Because what happens is, once this starts happening with some regularity, most people start reacting to it. So you see people develop a lot of apprehension about going to bed at night because, gosh, will I or will I not be able to sleep? Or you see people develop a lot of worries or anxieties. Or while they're in the midst of insomnia, they develop frustrations or even anger. There's a whole metaphor of someone being so frustrated they're not sleeping, they're punching their pillow. Or you start seeing people really focusing on what may happen the next day. I really need to get to sleep tonight. I have to go to work tomorrow. And when all these reactions are reasonable when you think about them, they also result in an emotional reaction. In all those cases, we get worked up, more agitated and energized. And before you know it, the process of trying to get to sleep at night, or even get back to sleep in some cases, not only is it not naturally triggering drowsiness, but it's been supplanted. It now triggers some level of sleep anxiety, apprehension, or frustration. And then what happens here is the more anxiety and frustration we have about not sleeping, the worse we then sleep. At the same time, the worse we sleep, the more it feeds into the perpetuation of these sleep anxiety. So you see this loop develop where these two things that just kind of keep feeding itself over and over again. So getting back to how I said this begins, it's something triggers a sleep and it causes it to get disrupted. And that person's reaction sets off this loop that can definitely, I've seen it run for multiple decades in some people. And a big part of this is, and you'll see this last time, is the beliefs or fears about not sleeping is a big part of what keeps it going. And again, just to kind of give you a brief summary of the type of common sleep anxieties or worries you have, one is about the next day consequences. As I mentioned, if I don't get a good night's sleep tonight, I won't be able to do work, I'll have trouble in school, you name it. Worries or perceptions of feeling just out of control about one's sleep. Gosh, I'm doing everything that the doctors are telling me and I still can't sleep. Well, why can't I not sleep? Or just the idea that a bad night's sleep tonight will lead into future bad nights of sleep tomorrow. Gosh, I can have a bad night of sleep tonight, but I can't afford not to sleep tomorrow. Or if, let's say I've had 2 nights, I can't sleep for 2 nights, but then I can sleep for 2 nights. I can go 2 nights without sleep, but I can't do 3 nights. Now, insomnia, the condition, and insomnia symptoms, both are common, but they have different frequency. The insomnia symptoms, we think about 1/3 of the adults have insomnia symptoms. And in fact, we have something called point prevalence, which means at any point that you find that people out there have insomnia, you think 20 to 50% of the population. So it's an enormous amount of people. When you talk about insomnia condition, it's not as common, but it's still really common. We think 1 in 10 adults have chronic insomnia. And I think this is even just reflected by, you see the tenets in most of these talks about sleep. People show up because a lot of people struggle with sleep. Now, when anybody can develop insomnia, not everybody's at the same level of risk. We know that women are more at risk for developing insomnia, especially when they're perimenopausal. We think that might be related to hormonal changes, but they're still not fully, explained to us why women are more prone to getting insomnia than men. As people age, there's an idea out there as people age, they need less sleep. And that's kind of been bantered around back and forth. So I can't just say definitively that's a myth or it's true, but what I can tell you, there's a number of reasons why as people age, they have more trouble sleeping. To begin with, people are more sedentary typically. And we know being active is helpful with their sleep. Oftentimes if people, let's say, have careers and they no longer work, they lose a significant source of their structure. You see people have more health issues. You see people have more medication. So there's a lot of factors that can feed into the fact why as people age, they have more difficult time sleeping. So again, it's still bantered around if people age, they need less sleep or not. I've read research on both sides. And those are just generally co-occurring medical conditions. And again, that's not just as people age, that's anybody. We know that people have more health issues, they have more trouble sleeping. So the question that also is, how does this impact our health? One of the things that's been, to me, a tremendous uptick over the last 20 years since I've been in this field is that we are more and more aware of not just that we could treat insomnia or sleep issues better, but that it really does impact our health. I tell people a good thing to compare it to is um, um, smoking cigarettes or nicotine use and obesity. Like both of those, it just cuts through so many different areas of health if this is untreated. We know people are at greater risk for cardiovascular disease, diabetes, obesity, hypertension. As far as mental health, we know people at greater risk for depression, anxiety, post-traumatic stress disorder, as well as substance use disorder like alcohol use disorder. And it affects us on a day-to-day basis, which anybody here has even had a few bad nights of sleep, they'll be able to speak on this. Your concentration goes down, so we're at greater risk for motor vehicle accidents. We see a drop in our quality of work and our occupation, and a greater use of healthcare. So like I said, it cuts through so many different areas. Now, I'm going to say a little more about the connections, not too much, about how it ties into mental health areas, because I'm a psychologist. So even though I focus on sleep, I'm also very sensitive and cognitive impact on how it affects our mental health. When someone has both depression and insomnia, the insomnia increases the risk for developing depression by 2. Okay. When we look at the symptoms within our test called the DSM-5 in psychology of what is comprised of a depressive episode, insomnia is part of our hyperinsomnia, loss of energy, which is 2 out of the, or there's a third one, 2 out of the 9 potential symptoms. So it really overlaps quite a bit. And in fact, we think there's what's called a bidirectional relationship, in that the more troubles I have with insomnia, the more risk I have for developing depression. But the worse I have for developing depression, the more risk I have for insomnia. And there's actually some research out there, though, again, this is what's not conclusive. When people have both depression and insomnia, if we can treat the insomnia with cognitive behavioral therapy for insomnia, which we'll talk a little bit about today, we can see in some people a drop in their depression. There's also a greater risk for suicide. So again, this cuts through so many areas. And we know there's an overlap between anxiety conditions, which I think is, pretty intuitive for most people. We have an anxiety disorder called generalized anxiety disorder. When people suffer from that, they just have a lot of anxiety on a day-to-day basis, irrespective of any stress in their life. We find that about 60 to 70% of people with this anxiety condition also have insomnia. And like the depression, there's also a bidirectional relationship. And also with post-traumatic stress disorder, this is one that's really gets attention in a lot of settings like the VA settings. And we're finding 70 to 90% of people with post-traumatic stress disorder suffer from insomnia. And lastly, substance use disorders. We know, we see that there's a bidirectional relationship between substance use disorders and insomnia. And it's not surprising because in the past, at least, if we go back to 2006, there was a survey of what is the most common way to address your insomnia. And the group that was most common, again, this is now granted over 15 years ago, was a combination of either over-the-counter sleep aids or alcohol. When I was new in my career, I remember I was going to talk to some physicians, and one of the physicians asked me, one of my patients said they can't sleep, and they asked me, what are my thoughts if I take a shot of whiskey to get to sleep? And I said, that's okay. What do you think? And I said, well, I get why it may help on a single night, but in the long run, it actually can be a slippery slope. And to be honest, alcohol, which while it can help fall asleep, it actually reduces the quality of sleep in the middle of the night. And we also know people that actually are to the point that they have an alcohol use disorder. If they also have co-occurring insomnia and that's untreated, their risk for a relapse goes up. So again, the connections are quite strong. So insomnia's been treated in a few different ways over the years. Probably the most well-known are either the prescription sleep medications or over-the-counter sleep aids. The Ambiens, the off-label use of something called trazodone, all the Z drugs. There's a lot of medications out there. Alcohol drugs, which you just mentioned briefly. On the behavioral side, we've had something called relaxation exercises, where we teach people just to kind of relax their body, which, while it can be helpful for a person that has maybe a bad night or two of sleep due to stress, for chronic insomnia, it doesn't do a whole lot. And then also sleep hygiene, which is probably the most well-known behavioral idea out there. I had the good fortune, I was trained by a psychologist who developed and brought sleep hygiene to the United States. His name was Dr. Peter Howry. He has since passed on, but back in the day, he was a sleep psychologist at Mayo Clinic in Rochester. And sleep hygiene is a terrific concept, and we still pay a lot of attention to it, and it's still important. but we don't see it as a standalone insomnia treatment these days. The approach that we now fall back on is one that I'm going to talk a little bit more about. It's called cognitive behavioral therapy for insomnia. So sleep hygiene, just briefly what it is. Sleep hygiene refers to a lot of the behaviors that we can do or do not do that can impact our sleep. So some of the more common ones are like if you have caffeine at nighttime. Is your sleep environment comfortable? Is it dark enough? Is it cool enough, quiet enough? And as I mentioned here, it is an important part of our sleep, but we don't consider it as treatment at this point on its own. You'll find it actually part of cognitive behavioral therapy for insomnia, which I'll get into briefly here. But as a standalone treatment, it's not really considered treatment within the sleep health community now. So what is cognitive behavioral therapy for insomnia? Well, like I mentioned, it grew out of sleep hygiene. It's a brief treatment. It usually takes 3 to 6 sessions. And when I say brief, I'm comparing it to when someone sees a psychologist for more traditional reasons, which can go months to years, which is it's a terrific process. But this is short. It's evidence-based. You have what evidence-based signifies in all healthcare treatments, that these are treatments that have been researched, and the research has been published in peer-reviewed journals and reviewed as it sounds. And so cognitive behavioral therapy for insomnia is one of only 2 evidence-based insomnia treatments. The other are the prescription medication. Now, it's made up of a handful of different techniques that were actually developed in different research institutions, which I'll go into shortly here. And what has happened here is we pull them all together here to get this approach here now that works about 75 to 80% of the time. And it's now to the point, it's considered the gold standard for treating chronic insomnia adults by the American College of Physicians, which is the largest group of internal medicine physicians in America. The American Academy of Sleep Medicine, which is the largest field of sleep medicine providers, and the American Academy of Family Physicians, which is the largest organization of family physicians in the United States. Now, the techniques are as follows, and I'll get into more detail shortly. One is called stimulus control, and basically a way to think of that is adult sleep training, and I'll get into more detail in a few moments. The second technique goes by either sleep compression or sleep restriction. And in this technique, we actually take advantage of the fact that by going to bed later, our bodies sleepier. We still pay attention to sleep hygiene. And the last main one we do is called cognitive reframing. We find for the majority of people with chronic and repetitive insomnia, they start responding to it in a way that actually makes it even worse. So a lot of my patients will describe being up in the middle of the night, let's say maybe 3 o'clock in the morning. They look at the time, they're like, oh, what an awful night. Here we go again. Well, while that's a reasonable reaction, it's a reaction that gets our body more agitated and actually even less likely to sleep. So it's cognitive reframing, we try to address those reactions in a way that doesn't essentially pile up on the insomnia. So those are the main techniques. I just want to backtrack for a second here. So I want to say a little more about these individually, because what you're going to find here, the steps I'm going to provide you all kind of pulls a little bit from cognitive behavioral therapy for insomnia techniques, but not in the full treatment here, because I wanted to give you all something that you can take with you and do on your own. So I'm just say a little bit more about each of these. In stimulus control, you're essentially having a person put themselves into bed in a drowsy state with the idea of reestablishing the association between bed and sleep. Okay. For sleep restrictions, I mentioned, we'll oftentimes have them push their bedtime later, sometimes even substantially, and get that sleep stabilized first. Because what we find here is we go to bed, we're not sleepy or drowsy, we're not likely to sleep, but if we're sleepy or drowsy, we are more likely. And with cognitive reframing, a lot of times we'll talk about trying to address the specific worries or fears about the sleep while a person's in the midst of the insomnia. So I developed a handful of techniques that I kind of pulled from all this. I think that I think on their own, if people do, can really help with your sleep, generally. But isn't a full-blown treatment, which would be really hard, I think, to put out in this kind of format. The first one is no internet an hour before bedtime. Now, getting back to the idea of screen exposure and light. So there's a blue light, from blue light that is generated by a lot of these screens. That, again, as I said earlier, when they enter our eyes, they can suppress our production of natural melatonin. Well, internet-based light is even that much worse, because when we're on the internet, it is incredibly stimulating and hard to put down. So people, you find them staying online long times, or they have a really hard time getting back to sleep after being on. So I really strongly encourage my patients for that hour before bedtime, there's no internet activity. Okay. Now there's an old adage, go to bed at the same time and wake at the same time each day, which is a correct recommendation under some situations, but not all. If a person has trouble falling asleep and they keep going to bed at the same time, that actually is going to feed into the insomnia. So in those cases, as a starting point, you do want to wake up at the same time each day, but you don't want to go to bed until you're generally drowsy, so not too early. And what I mean by that, it's actually better to go to bed a little bit later than a little earlier, which seems counterintuitive to a lot of insomniacs. So a lot of insomnia, they think, well, if I'm not going to sleep well, if I go to bed earlier, if I have insomnia, I have a better chance to get at least some sleep. But what happens, in fact, is it actually leads to more trouble sleeping and more fragmentation of sleep. So actually, it's better to temporarily go to bed a little later with the same wake-up time and wait to go to bed till you're drowsy. The next one is to really limit napping. Now, if someone were to come to my clinic and they have no other health issues, I would say no napping altogether. But we find there are some circumstances that napping might be important. We know as people age, they may nap more. We know as people have maybe issues like pain. So the rule of thumb is to try not to nap, but if you are really limited to about 30 minutes at most, once a day. Only use the bed for sleep and intimacy. And this gets back to the Pavlov or classical condition. We want to maintain or reestablish that being in bed is a natural trigger for drowsiness. Avoid looking at the time during the night. What happens for a lot of people, seems to be almost like a gut reaction when they're having trouble sleeping to not know what time it is. Well, how long have I been awake? Well, how much more time do I have to sleep? And we find is usually what drives that urge is that sleep anxiety. And in fact, one of the ways you can tell you have that sleep anxiety is if you're saying to yourself, I probably shouldn't look at the time, but you have a hard time not doing it. That's indicative that sleep anxiety is there. Because when you talk to someone who does not have anxiety about not sleeping, it's very easy for them to avoid looking at the time. And the last one here is what's called a cognitive reframe. So what happens for mostly when they're in the midst of their insomnia, they get hyper-focused on an individual night. So they don't think as much about last night, but tomorrow, but they're really caught up in tonight. So one of the things that we really try to do is we try to diffuse that sleep anxiety by trying to normalize it. We try to take away the catastrophizing that people tend to do. So if you're in the middle of a bad night of sleep, if you can, just try to reassure yourselves, yes, I may be having a bad night of sleep tonight, and you know what? I may even be more tired tomorrow, but even if that happens, I'll still be okay. And one of the reasons we know this is true is the way our body responds to a bad night of sleep tonight, for example, is we're going to be naturally sleepier tomorrow night, and that's going to benefit us. And so my hope too is if you're able to follow some of these ideas, that you too, like my daughter Tal here, can have a good night of sleep. Now, I know there was like the questions. Oh, so and then if you like I said, I now have a private practice. It's through telemedicine in the DC, Virginia area, and I can reach at the number of 202-933-9406, or the easier way to remember is just sleeppsychologist@gmail.com. And if you reach out to me through any of these ways, even if you have questions, you can reach out to me that way, or if you think you might be interested, but you're not sure if you want to, feel free to reach out. I'd be happy to kind of walk you through what this would look like. And at that point, you can decide if this is something you want to pursue or not. Now, I know there were some questions about narcolepsy, but what I'd rather do, if it's all right, is I just want to open this to questions as a whole, and we can talk about narcolepsy as it is. Let me go and get into the chat here. Or
I can monitor the chat. If somebody wants to put in questions in the chat, then that might be easier than unmuting. So if you have any questions, you want to go ahead and type them in the chat, and I will happily share them with Dr. Rosenblum.
And as you do with audio, I'm going to talk just a little bit about narcolepsy because that was
okay. Yeah, thank you.
So narcolepsy is it's called a condition of hypersomnolence, and when people have it, they are excessively sleepy, and they can have these what's called the sleep attacks. Where they can do most of it, they just feel this strong compulsion to sleep. One of the things you'll see with it, sometimes people have something called sleep paralysis. And what that is they're awake but they feel like they cannot move. Sometimes you'll see people experience like hallucinations around bedtime, around sleep as a whole. And they also can have what's called cataplexy. What cataplexy is when there's an emotional reaction, they feel their muscles just give away. It's a condition we know far more about now than, let's say, 20 years ago. The treatments they have typically tend to be stimulants. And for that's something that's kind of outside my purview. I'm a psychologist, so I don't prescribe medications. but you'll find most sleep physicians are very well equipped to treat that. I know actually the one of the sleep physicians that put me in contact with the organization here was Dr. Nee, who's out of New Jersey, and I would suspect that Audrey then would have contact information. So I think it'd be good resources if this is something you feel like you're struggling with. From the behavioral side, it's a little less what we can do. With the behavioral side, actually, it's almost more of a health psychology approach. What I mean by that, from the behavioral side, there's not a whole lot we can do to treat it, but what we do is if I were to sit down with someone with it, I'd be more talking about really just coming to terms with it, which I know doesn't sound very it doesn't sound very hopeful. I get that, but for those who have it, it's a tough condition because there's an element of unpredictability to it, definitely. So I don't know if there's more questions about it, but that's just like a brief overview of it.
Okay, well, thank you. A whole bunch of questions have come through now, so I'm going to try and pull some out that I think are really relevant to everybody. One person said, if you do go ahead and take a nap, is it better to nap in bed or on the couch? In other words, should you stay out of the bedroom if you nap?
It's better to nap on the couch, and that's actually a good question here because it gets back to the whole idea about the sleep onset association here. I really, the challenge is when people nap in their, well, let me restate this. If you reliably sleep in your naps, then it's probably okay to nap in bed. But it's by my experience when people who nap, not everyone, but it's not uncommon, they're kind of drifting in and out of sleep. There's some napping, but there's also just some resting going on. So if you purely are just sleeping, it's probably okay. But if you are someone kind of drifts in and out, I would do the couch.
Okay, thank you. Somebody else asked, what happens when you feel really tired and sleepy, then you get into bed and you wake up?
Okay. So that's at the heart of insomnia, or the sleep initiation for the beginning of night insomnia. There is insomnia that's in the middle of the night, early morning too. And that's a whole aspect of the Pavlovian response. So what has happened here, when going to bed has become a trigger for all this sleep anxiety, this sleep apprehension, what you'll see at times when people just get into bed, that itself triggers a little bit of, I guess, it doesn't have to be anxiety, but energy. So you find this out, plays itself out is when someone's not actively trying to sleep, they doze off. But once they start to actually try to get to sleep, that trying to sleep now triggers that arousal reaction, and that's what they're experiencing here. And you'll find for a lot of insomniacs, that is really one of the more compounding things is they'll claim like, listen, I fell asleep watching TV or reading on the couch, and I go to bed, I can't fall asleep. I don't know why. Well, that's the reason why. It's the trigger. Going to bed now has developed into a trigger for some kind of emotional arousal versus drowsiness.
Okay, thank you. As you can imagine, there are many questions, so I'm going to try and consolidate a little bit. Somebody is asking, there are a lot of natural remedies out there. Any you recommend, like taking cherry juice, for example, or anything? You know, people will hear. I guess maybe I'll reframe the question. How do you evaluate some of the ads, YouTube videos, all the different types of things encouraging different types of remedies for sleep? Is there any way that you can assess if these have any evidence, as you mentioned before?
That's a terrific question. So let's just take one step back to answer why there's all this out there. It's out there because it's a problem that so many people struggle with, and the solutions oftentimes feel elusive. Okay. As I mentioned, I rarely get somebody who comes to my clinic that this is their first try to do with their sleep. I usually get people that they've been having for years, decades, and these are people that I'll get this out. I've tried everything. I don't think you can help me out, but I'm desperate. Okay, and I don't take that personal. That's not about me. I think that's about, you find for even people here who have had long-term insomnia that are attending, they feel like they've tried so many things that at first sounded promising and then did not work out. The reason why things like cherry juice is the idea behind it has melatonin in it. And melatonin is the most probably well-known supplement related to sleep. And we look at the research, the researchers are not very compelling. It's actually pretty weak in its findings. Where we are more prone to use melatonin, at least in a sleep clinic, are for the night owls. Because we're trying to like retrain their circadian clock. And melatonin, you use it a very specific way. You don't use it the same way for insomnia. Nevertheless, there are some people that say they take melatonin and it works. So it does work for some people. As a whole, the supplements, there's not a lot of support from them. You're not going to find too many sleep specialists go to that, despite the fact there's so many out there and they market so much. The only two things that are evidence-based on strong are the prescription sleep medications and cognitive behavioral therapy for insomnia. So as far as evaluation, I tend to be, it's sort of like, well, for a few years, I did some behavioral sleep work for the Hazelden and Betty Ford Foundation. And because there's, as I said, mentioned, there's a lot of sleep issues for people with substance use disorders. And what you find is one of their go-tos, they were using melatonin with this off-label use of a antidepressant called trazodone. And the idea behind them is, from at least from a side effect concern, they didn't see as concerning, let's say some of these sleep aids like, Ambien and those sort of things. So from that standpoint, they may be a better option. And there are some patients I saw that it would work for, but as a whole across the board, it really doesn't get to the heart of it, of chronic insomnia. So chronic insomnia, the heart of it is this manifestation of the sleep anxiety that is triggered by trying to sleep. So if we think about it, any of these sleep aids, all they're trying to do either is relax someone or make them feel sedated, but it doesn't necessarily directly address why the insomnia is happening, if that makes any sense. So sorry if that's a longer answer than what you're looking for, but that's kind of my take on it.
No, I think thank you. That makes a lot of sense. And from what I'm hearing you say is that a lot of times with sleep insomnia, there's an underlying anxiety that perhaps the CBT is well suited to address. Does that make sense?
Kind of, but it's not a general anxiety. It's anxiety of not sleeping. It's very specific.
Okay, thank you. Just somebody asked a question, and you touched on it a minute ago when you mentioned the Betty Ford Clinic and people's substance abuse issues. This is coming at it from a little bit different angle. They said that they are noticing in the hospital, I don't know if it's a hospital that they work in or that's near them, that a lot of teenagers are coming in and saying that their sleep issues are addressed by cannabis, and they would like to actually explain to them that that's false. So I guess the question is it false? And if so, how do you explain to people that cannabis might not be the best way to treat their sleep issues?
So this is part of the offset or offshoot of the legalization of marijuana and how it's going across the country here. In Minnesota, where I'm stationed, I mean, this just passed this last couple of months. So you are seeing that people using like the CBD gummies and what have you here. And again, I can't speak from the research side, but I know patients are trying to use it. I've had some say that it's helpful, but to be honest, most have not. But this is what I fall back on. When you look at the research for people who smoke marijuana, again, with this, I know not the exact same thing as these, let's say, gummies. While they may turn to it as a sleep aid, people who chronically smoke marijuana have a far greater risk of having chronic insomnia than the general population. So you kind of see from both sides here. So on the one hand, is it relaxing and could that be helpful? Maybe. On the other hand, it also may be contributing to the chronic use of the marijuana, and there's something going on there. It's sort of like, I think it's been this way for a long time, and even like this with people with alcohol use. In some situations, people find it's helpful, but in the long run, it actually seems to be a greater risk factor if you do both of them to feed into each other.
Yeah, okay, thank you. There's so many questions. I'm just going to try and take a couple more. Is that okay with you? Can you stick around? Okay, great. Some people are asking, how do you feel about doing some light exercise right before going to sleep? Could that help?
I'm sorry, just before you
That's another very good
answer
question. So,
that question, can we have the new interpreter spotlighted? Our client had mentioned he had lost the interpretation.
Sure. Is this
Thank you. Jasmine?
This is Jasmine. So Aviva is spotlighted.
And we just switched. Can we switch?
Oh, you switched back again.
Yeah, thank you.
I appreciate that.
Sorry
Yes,
to interrupt.
absolutely. No, absolutely. While I do that, the question again is about exercise, I guess, before bed, or light exercise before bed.
is it okay? Go ahead.
Actually, if you could wait one more minute, I'm about to spotlight go back to the, okay, please.
So the old sleep hygiene adage was no exercise in the evening, and that's what we used to follow. But as the field has become more, I guess, advanced and developed, it's not so all or nothing like that. First of all, the basis why not to exercise in the evening was a concern that when you exercise, especially your heart rate up, your respirations increase, your core body temperature elevates, your heart rate increase. And the thought was, well, if you're in that state, it'd be hard to sleep. And there isn't truism to that. But what we found is that actually it was overly broad. And now through our I guess research over the last about 10 to 15 years, we're now advising people that you probably don't want to exercise 2 hours before bedtime, but up until 2 hours is fine. And in fact, it can be very beneficial in that, like certainly say a light exercise. If you do some cardio work for 10 to 20 minutes where you get your heart rate up, when you're done about 2 hours for bedtime, that actually helps a lot of people sleep. Now, a lot of these sleep hygiene ideas, it's not one size fits all. So if you do it, it seems worse, and obviously don't do it. But for a lot of people, it's actually really helpful.
Thank you. Okay. Last two questions. One is, can you address sleep apnea and insomnia? And somebody mentioned, and I assume that also, and CPAP machines.
Okay. So sleep apnea is basically referred to as sleep disrupted breathing. And what happens here is the breathing is disrupted as someone sleeps. So you see things like their oxygen levels drop, they snore more, their quality of sleep drops significantly. And there's really two types of sleep apnea. I'm kind of oversimplifying it. One is obstructive sleep apnea, which is where the airway where we breathe is impinged upon. So if you can envision like when someone's trying to blow a horn, when you narrow the airway and try to force air through it, it makes a sound, and that's one of the reasons why we snore. The other is called central sleep apnea, and that's more just like the brain is not communicating well with the respiratory system. But in both cases, we're not breathing well, and it has a lot of health issues. It's really important to treat. And probably the gold standard treatment is a CPAP, which is mentioned here. And what a CPAP apparatus is, it's a device that either goes over the nose or the mouth, and it forces the airway in there to stop that problem sleeping. Now, there's other versions of CPAP, things like BiPAP or what have you here. But that is really the gold standard treatment. Now, there are other things out there, there's like something called an adjustable oral appliance. So sometimes if you have mild obstructive sleep apnea, that goes in the mouth and just opens up the airway a little bit. There's also things called like positional therapy, where you have to give someone, let's say, a wedge, and you try to lift their head, and that can also help them breathe better. But again, these things can be helpful, but the really gold standard is the CPAP. And there are actually some other like advancements in the last 10 years. There's something called Inspire, which is actually a pacemaker essentially, and it's put in the body here, and it controls the back of the tongue to open up the airway. Again, and I'm sure you guys all know Dr. Neil, at least audited him. He would probably be a great resource too for people who have questions about that too, or are interested in that. I don't know how close you are to his sleep clinic, but he's a sleep physician here, and I suspect these are things that he's very frequently will treat with.
Thank you. Well, we'll try to get that information out to people as well. So with just quick follow-up then, with sleep apnea, is there ever a role for CPT along with that as well, or it's a really different issue?
Oh, I see. Okay, there's two ways. So one is there are some people that just have co-occurring insomnia and sleep apnea. So it's not uncommon when I go to the sleep clinic, the patients refer to me, I may address the insomnia with CBTI, while the physicians are treating this sleep apnea with, let's say, a CPAP or the dental appliance. But in some cases too, there, CPAP, well, it's very effective. Some people have a hard time acclimating to it. I mean, it can be really tough for some people. So for some people, they'll send them through a sleep psychologist will help them with something called systematic desensitization, which is to help them just become used to wearing the CPAP. So those are two different ways where a sleep psychologist may use to provide some help.
Okay. All right. Two more quick ones, and then we'll ask Dr. Rosenblum to give us his contact information in the chat for people who want to follow up with him and learn more about his private practice. So the last two was, let's say you're taking Ambien and it seems to be working. Is there anything wrong with using it for long-term use to address insomnia?
Well, there's a medical side and then the practicality side. So I'm going to talk about the medical side first, and then we'll get to the practicality. So Ambien, if it's working, that's terrific, but it does have some side effects. One is next day agonist. So about, now 15 years ago, the FDA reduced the recommended starting dosage for women from 10 milligrams to 5 milligrams, because they were finding that women who typically metabolize things slow were waking up still under the influence of Ambien, so they're out driving other foggy. So we have to be cognizant that one of the common side effects is for some people they wake up groggy, and that could have a risk if you're doing things like driving. Second, for some people, but it doesn't sound like the first of the questions, there are other side effects. You see people do things like sleep eating, sleep driving. There are scary stories. When people first see stories, I think it's kind of funny. Oh, I went to the refrigerator and I came out and I found food sitting on a thing. But there are stories out there of people driving under the influence. They get out there and start driving. And so there, again, while it's not common, there's that risk factors. Okay. Now let's talk about the practical. What is happening behind the scenes, there's a lot of pushback from using the sleep medication. Because first of all, when you look at the data, the CBTI, you look at the data for Ambien, for example, it works between about 62 to 63% of the time when you do look at the meta-analysis. Cognitive behavioral therapy for insomnia has a better success rate, about 75 to 80%. Plus, it doesn't have the health risks. Plus, it also can actually resolve the insomnia, whereas medications just deal with insomnia symptoms on a night-to-night basis, meaning cognitive behavioral therapy for insomnia can actually cure it. Medications don't, they just deal with the symptom. But what we're seeing too as people age, a lot of these sleep medications have risk for falls. And there's something out there called the Beers criteria. And this is a list of medications that are scored by the geriatricians because of risk for falls, and Ambien and numerous sleep medications are on there. So in practicality, what's happening here is people are now medication for 15, 20 years, they're doing fine. They're giving their doctor say, listen, I don't think this is such a good idea anymore, especially if you're at risk for fall. They say, we're gonna have to take you off it. And you can imagine what that must be like for people. And it's scary, it's frustrating, it's a lot of things. So the practicality is that is going on behind the scenes quite a bit. And I'm not saying anybody's just about to do that, but it's out there.
Okay. So thank you. That's really important information. Okay, there are lots of different questions. I hope that we got to cover at least the big categories. I am going to ask Dr. Rosenblum to put his contact information that he mentioned. Could you put that into the chat for everyone? I don't know if you're not able to chat everyone, you can take it, send it to me. I'll go ahead and then send it to everybody. So if you can, you might only be private chat enabled, but I'll go ahead and send it. And I want to just also take this opportunity to echo also what I'm reading in the chat, and on behalf of Beaker Home of Greater Washington and myself and Ellen Haber, to thank Dr. Rosenblum for taking time out on the Sunday morning to address a question that, I don't want to be too punny about this, but literally has been keeping people awake, all night so that they could finally get some guidance. And I definitely think that you added a lot to this conversation, and your expertise and guidance is something people were really looking forward to hearing and deeply appreciate. So thank you for all of that. So if you want to go ahead and send me your contact information, your best way for people to reach out to you, please do. And I will go ahead and send that off to everybody.
Okay. And thank you, Audrey, and to Ellen, and to all of you for your attention. And yeah, and like I said, if you just have questions, I'll send it to Audrey, and I'll ask her then to email it out to you guys. If that's but yeah, if you just have general questions, I'm fine with that as well, if we didn't get to some of them. And yeah, just thank you, everyone, and I really appreciate this opportunity.
Thank you. Okay, so I have everybody who registered email us. We have a recording, and we will share contact information for Dr. Rosenblum. I hope everybody has a great day and a restful evening. Thank you.
Thank you.
All right. Bye,
Thank
everybody.
you.
Thank you, doctor.
Thanks, Audrey.
Thank you.
Doctor.
Thank you,
Thanks to Vicar Huli.
Rabbi Shulal.
Well, everyone. And thank you, Jasmine and Aviva.